Okay, what's up? Horner syndrome. Let's do it. If you haven't watched the meiosis versus the mydriasis video, this is a pretty good time to go do that. It'll be very helpful for this video. But if you don't want to, here's a quick recap. The sympathetic pathway that's responsible for dilating the pupil starts in the hypothalamus, goes down the spinal cord, exits the spinal cord around C8, maybe T1-ish, comes back up along the sympathetic chain, hits the superior cervical ganglion, and then splits into different neurons that are the third order neurons that do different things. Either innervate the pupillary dilator muscle, hit some sweat glands of the face, or hit some smooth muscle in the face and the eyelid. All right, now we're all caught up. So Horner syndrome is literally just a defect anywhere along that pathway. So if you have a defect in the first order neuron, anywhere from the hypothalamus down to about C8, then you're gonna get Horner syndrome. And examples of things that can do that: a pontine hemorrhage, lateral medullary syndrome, some kind of spinal cord lesion that is above T1 before it exits the spinal cord, like a syringomelia that's pretty late stage, or even a Brown-Séquard syndrome that just hits that one side of the spinal cord. And examples of things that can compress the second order neuron are pretty much anything that can compress it. But most commonly it's gonna be a Pancoast tumor in the upper lobe of the lung. And examples of things that can affect the third order neuron are pretty much just a carotid dissection. And because the sympathetic tract affects the three things that I mentioned earlier, you're gonna get ptosis, which is a droopy eyelid because you lose muscle of the eyelid, which is which muscle? It's a superior tarsal muscle. Not super important. They're probably not gonna ask you about that, but kind of cool to note. You're also gonna get anhidrosis, which is an absence of sweating in the face because you knock out the sympathetic innervation to the sweat glands of that side of the face. And you're gonna get a meiosis, a consistent meiosis in that eye because you're knocking out the entire sympathetic innervation to that pupillary dilator muscle. So how do you remember that? P-A-M, ptosis, anhidrosis, meiosis. So PAM is. And the only way they pretty much ever ask this is with a Pancoast tumor. They'll be like, oh, they have some eye issue, they have some giant mass in their lung. They'll usually show you a picture, and then you could probably pick Horner syndrome or pick like the sympathetic issue or however they word it. Okay, that's pretty much all you gotta know for Horner syndrome, but there are a couple small things I do wanna mention. They probably won't test you on them, very unlikely, but I have seen a couple comments about it, so I do wanna mention it. So the first and second order neuron are pretty much exactly as I described them earlier, but the third order neurons branch off a little differently. The two neurons that innervate the eye, so the one that go to the pupillary dilator and the one that go to the superior tarsal muscle, they branch off at the carotid bifurcation and they follow the internal carotid all the way up to wherever they need to be. And the other neuron, the one that innervates the sweat glands of the face, also branches off at the carotid bifurcation, but it follows the external carotid artery. So there are some circumstances where you can get an internal carotid dissection and you'll have the ptosis, the meiosis, but you won't have the anhidrosis. And that's not a huge deal for step one, but I'm pretty sure I've seen it in some kind of UWorld subtext, like in a parentheses or something, so I had to mention it. All right, that's it. Now you know Horner syndrome. Now you know giant tumor in the upper lung. You're gonna get this dilation in your eye. You're not gonna sweat in your face. Now you can get that question right. And as always, Anki cards and a PDF to help you study in the description.